And sometimes that reassurance makes all the difference because mental health is so delicate.
Welcome to eShadowing, and my name is Rashadah. And tonight we have Rashadah that's going to join us. She's just having some issues logging in, but she should be on. So I'll just take the time to answer some questions until Rashadah gets on. Hey everyone, hope you're having a great week, or happy Monday, start of your week. The schools require a log for hours. Well, when you do your CASPA application, they will ask you how many hours you have, and I believe they may ask for verification of your hours, but I think it's just dependent on the school that you're applying to in terms of a log. This is recorded. Somebody asked if this is recorded. This is recorded, and it will be up. The replay will be up at the end of the session. It should be up within 24 hours. And we have Rashadah.
Hey, can you guys hear me?
I can hear you, but I can't see you.
Oh, no. Okay, there we go.
Oh, hey. Hello. Hi. Thank you so much. Hi, Rashadah. Thank you so much. I'm pronouncing it right?
Yes, you're pronouncing it right.
Okay, great. And I'm Rashadah.
Nice to meet you.
Nice to meet you. Okay, guys, so Rashadah is in the field of psychiatry, and I've been looking forward to this all week because psychiatry is a very highly specialized field, and not many people like to get into psych. But of course, as you all know, mental health is such a big issue, especially during this time. And we have some questions for Rashadah, and of course, at the end, we're going to do 1 or 2 case studies if time permits. And Rashadah, the case studies are not meant to be asking anything medical related, just more so about the way you take a history, physical, and certain things to know when dealing with a patient with a mental health issue or psychiatric patient.
Okay.
So guys, Rashadah is a Psych PA, as I said. She not only does that, but she also does mentoring. She does coaching. She has her own YouTube channel. She's an NCCPA ambassador. And so I'm so excited to have her, and I thank her for being here tonight.
Yes, thank you for the opportunity. I was so nervous all day. I was like, oh my God, this is my first live. I was like, oh my God. But I was so excited. Thank you for the opportunity to be able to speak with you and your audience, and also to be put on the limelight and then in the crossfire and asking questions on the spot. It's exciting.
Oh, of course. Thank you. So we're going to first start off by finding out a little bit about you, how you got into the PA field, and how you specifically got to be in the psychiatry specialty.
Yeah, so my name's Rashadah Jordan. I went to Coastal Carolina University for my undergrad, and my undergraduate degree was a Bachelor's of Science in Public Health. And then I knew from then I wanted to go into PA school because when I was in high school and middle school, I was involved with a local pre-med group that had meetings every Saturday in the hospital, and they had guest speakers. And one Saturday, we had a guest speaker that was a PA. And she intrigued me because she was like, yeah, you don't have to go to school as long. And I do, I think at the time she was family medicine in Greenville, South Carolina. And I got her phone number. I reached out to her. She told me to go for it. And that's all she had to tell me. After that, I started doing my research. When I was in school, I actually looked up my prerequisites. I kind of had a feel for what schools I wanted to go to, and I completed my prerequisites as electives. So I didn't have to do post-bac or anything. So when I graduated, I was prepared to apply to PA school. So funny thing, I actually had my PA school interview on my 21st birthday. And I never forget that. I went in there and I was so nervous, and I was chattering, and I was like, hey, so I go to Coastal Carolina, when you're in that college mentality and you're like, yeah, go Chomps and all this stuff. And they're like, yeah. So I graduated college, I don't know, several years ago, and I have 3 kids and a husband. And I'm like, oh, so I'm not, I was under the impression that everybody was around my age. And I was just like, oh, so I was actually the youngest one in my class.
Wow, that's impressive.
Yes. And I was like, oh my goodness. So it was some struggles, but after I would say the most most challenging was my didactic year, because you're getting adjusted and acclimated to PA school and how to study and things like that. Clinical year, things got a little bit more easier. And for the life of me, I always wanted to be a pediatric cardiologist. I thought I was going to go to school for that. And when I decided PA, I was like, I'm still going to do pediatric cardiology. That's what I want to do. And then I started learning EKGs and I was like, no. So I had to figure out what I wanted to do then. So I was like, oh my gosh, well, I guess family medicine, I'm good at family medicine. And that was my first rotation, rocked it. I was like, yeah, family medicine. But then I went and did psychiatry and fell in love. It wasn't that I ever thought that I would be in psychiatry. It's just, it came so natural to me. Like, we started to review for boards, and every question they asked, no matter what specialty it was in, I was always raising my hand, and I got all the psychiatric questions right. And my friend was like, you should go into psychiatry. And I was like, really? You think so? And she was like, yeah. And so maybe 3 months before I graduated, I started looking for jobs. I applied everywhere. And the first job that got back to me was actually the job that I currently have now, psychiatric outpatient. Went for it, been in love ever since. So I didn't pick psychiatry. Psychiatry kind of picked me. And now I'm stuck with it, but I love it though. I love what I do. It's very rewarding.
So how long have you been doing psych?
Come January, it'll be 2 years. So I'm still a newbie out of school. Yeah.
So that's the only field that you've done, right? That's the only specialty. I mean, okay.
Yeah.
Okay. Wow. So your school offered psych as a mandatory rotation?
Yes. We did.
Okay. Mine actually didn't. Psych. Nobody. Well, I don't even know, unless it was. Some people took it as an elective, but it was not mandatory.
Wow. No. Yeah.
Yeah, I think that definitely should be a mandatory rotation for all schools, just nationwide, because you guys would not believe. I work in the ER. You wouldn't believe how many involuntary holds that we have to do. In Georgia it's called a 1013. In Florida it's called the Baker Act. How many of those we see? How many psych patients? How many times I have to write something up? How many times social work has to get involved? So it's something that's definitely overlooked, but is a serious issue. It is. All of my patients have had some form of a psychiatric condition. I a lot of them. So it's definitely should be addressed more.
Yeah, I think so. I mean, mental health is just as important as a broken bone, as a heart attack, as anything else. And a lot of people say, well, I don't want to be on medicine. And I'm just like, well, if you had diabetes and it was life or death, wouldn't you take your medicine every day? Yeah. I'm like, oh, okay, well, if you have migraines and you suffer from migraines, don't you take that medicine every day? And they're like, yeah. I said, well, it's just as important. Right. And then when I put it like that, they're like, oh, yeah, well, I guess so. I'm like, it is. It is.
Exactly. And a lot of people don't see the significance of it, or that it's such an issue until it's too late, until you have, right. I've had 15-year-olds that came in, their parents found them and it was a hanging, unfortunately. Mm-hmm. I've had what is it? Especially, with young adults, they take pills, they do certain things. Oh, yeah. They've had, not the best life and so many issues. And it's something that definitely needs to be addressed and talked more in healthcare, not just physical medicine, right. Mental health.
Right. I agree. I see a lot. I work with a lot of foster kids, and I work with a lot of kids who's been incarcerated. I work with a lot of kids. I don't know, I just see it all over the board. Sexual abuse, physical abuse, neglect, witnessing domestic violence, or just being around something that was traumatic to them. I see it across the board, children, adults, because I see 5 and up. So
okay, so you work with both children and adults. Okay.
Yeah.
Wow. Right. Is that when they determine that mental health starts at age 5, or can it be any younger than that? Do you see 4-year-olds that have, or 3-year-olds? Okay. Well,
no. Yeah, no, because a lot of medications are only FDA approved for 5 and up, and we're kind of kicking it with 5. A lot of them are 6. So You gotta be really careful. If we use it, we decide to use it off label with letting the parents know it's FDA approved for 6 and up. So if da 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 happens, contact the office type of thing. But I do see 5, but that's about as low as we'll go.
Okay. So you try not to start the 5-year-olds when they're that young on medications? Do you usually try trying to adjust their behavior and seeing a therapist and other, non-pharmacologic options first?
Yes. It just depends. If I have a 5-year-old that's really off the chain and we have a very strong history of ADHD, and I'm just like, okay, let's try some 10X. Or something short acting like 10X or something like that first, I will not turn to a stimulant unless it has to be pretty significant. I'm really careful about what I use in my kiddos and how much I use. I usually start very low but then go very slow with everybody, but especially my kiddos, because if something happened, I'm reliable. I do try to give the parents all the information that they need and let them know, we're using this off label. And usually by that point, some parents are just so exhausted with everything and the teachers calling and things, and their behaviors are just like, whatever at that point. And I'm just like, okay, usually nothing crazy happens. But, you have to make sure you give that patient education and let the parents know, this is what to look out for if anything crazy does happen. So.
Right. Okay. So can you tell us about involuntary holds? I know it varies by state, but what is it called? You're in North Carolina?
I'm in Virginia.
Oh, Virginia right now. Okay, Virginia. What is it called in Virginia? Because like I said, in Georgia, it's referred to as a 1013, like the 48 to 72-hour hold. Can you tell us about that process and qualifications for it, how long they're on the hold for, what they present as patients come in with that? Because I think that's something you'll see throughout any specialty that you're in.
Right.
You have a patient, you can be in family medicine, and the patient tells you, oh, I'm depressed, I want to kill myself, or I plan to do this.
Right.
So you need to know the proper steps to take.
Yeah, so for me, it's a little bit different because I'm outpatient. So for us, our protocol is depending on if I have a patient that comes to me and say, I'm suicidal, I have a plan, I have intent. Usually we will call the police. I think it is a TDO. And then, the parent, of course, has to be with them. And they take them to the ER, and usually the ER will evaluate them, think if they want to admit, or if they don't want to admit, they will send us to our crisis program. That's why my employment or my employer is pretty cool. It's like a CSB so to speak, because we offer crisis. So I actually go and do crisis rounding on every Monday of the week. And so if they don't meet the qualifications for being involuntary commitment, they do come into our crisis program for 7 days, or depending on how much their insurance will pay for. And we will round, and there's a therapeutic environment. We have a sensory room, we have the gym and all this other stuff. We get therapists involved. I come in round, and then if they don't have psychiatric services, we get them plugged into them. But as far as I guess in involuntary holds and things like that, I've seen that on rotations, but that's not something that we necessarily do. I mean, it really has to be bad. I think one time we had someone that came in and said that they had access to firearms, and he was clearly psychotic, and we had to call the police for that. Certain things, it just depends on the details of the situation. But so far, besides that one person, I haven't had to really get the police involved or anything like that, or any holds or anything like that.
Okay. So, but if they do get placed on a hold, it's usually 48 hours, 48.
Yeah, 48 hours ish, and they're in the ER until they can find them a bed or a place. Usually what's nice about our hospitals here is we have, I don't know if you're familiar with Virginia, but we have a big hospital named Carilion. Everybody knows about UVA, but UVA is up the road. So we got Carilion, we have Lewis Gale, and they all have their psychiatric unit. So you don't have to go looking for a place to put them. They can be transferred upstairs within the same building. So that's really, really nice. So they don't have to go far.
Okay, thank you for that. Okay, yeah. So are there any certifications needed to get into psychiatry or to, I guess, advance your specialty?
I mean, I didn't have anything when I came in but my PA degree and my certification. That's it. I just recently found out maybe 2 days ago that I passed my CAQ, but that wasn't required. So I went, that was a personal thing that I wanted to go for.
What is the CAQ?
It's the Certificate of Added Qualifications, and the NCCPA does a good job at making sure they have one for peds, they have one for emergency medicine, psychiatry. I think they have one for cardio. I'm not sure, but it's just a couple of them that they have for specialties. And all that is just saying that you are dedicated to your specialty and you're really, really I won't say like an expert, because I don't consider myself an expert or anything like that, but you know your stuff. Yeah. Yeah.
That's nice. Okay, so let's see. Can you also discuss next a day in the life of a psych PA, or just specifically your job, what you do when you clock in, the type of patients you see, how many you see in a day, and interesting cases?
Yeah, so a day in the life for me is I start work at 8 o'clock. So maybe I'm up by 7:30, or I would be at the office by 7:30. I would prep all of my charts for the morning. And usually right now, what a day looks like for me is pretty much telemedicine all day long. We've been working from home since the shutdown in March. So I start by either seeing our group homes, which can range from, we got little kids from 10 years old to 18 years old. Sometimes we have therapeutic foster group homes that we see, or sometimes we see the incarcerated adolescents. So sometimes I'll start with them, and then in the afternoon, I'll see my regular follow-up patients that I would normally see inpatient or in person, sorry. And I'll either phone call them or do telemed sessions with them. And usually my day is over by 4 o'clock, and I have just about enough time to finish my charts and sign off on them. And lunchtime, of course, is from 12 to 1. So that's pretty much like a typical day for me.
Okay. All right. And what about patients that you would see? Like, do you see specific diseases, or just any and everything?
I see anywhere from anxiety and depression to bipolar, conduct disorder, personality disorders. Like I said, a lot of trauma, PTSD, nightmare sleep disorders. I treat a lot of sleep apnea, believe it or not, in psychiatry. I've seen sleepwalking. People come in and complain of that. That was really cool. Schizophrenia, schizoaffective disorder, tics. I treat a lot of neurological disorders. People with seizures. I see a lot of epileptic kids, like autism disorder. I see everything. Yeah.
So I know that you said that you're working from home now due to COVID. It's completely remote. How have your patients' lives changed due to COVID? Has everything heightened as far as like their anxiety? Have you had to change medications? Do you have more patients now because of COVID, and patients that are stressed, needed to see a psychiatrist, or how has that?
Yes, so it's been stressful, I think, on both ends for the patient and for me. People don't think of me as a person when they call me. They just know that they need help, and so they want to talk to someone. But I think it has been stressful on both ends, because everybody wants to turn to medications in the midst. Like, we're all feeling stressed, right? This is a stressful time for all of us. But I've had an increase in drug abuse because a lot of people are turning to the streets to get Xanax and different things like that, because they think that's what's going to help them calm their anxiety down. Or just overall, people have had an increase in anxiety, and I've had to increase anxiety medications, non-controlled. I've had to refer to therapists and people who normally would be against counseling and talking to someone, because there's a stigma against that too. People have been willing to go in and talk with someone when they know that I'm not going to give them what they want. They're just like, okay, let me try this. And they actually see that it works. I've seen an increase in depression. Of course, the time change just happened, and 5 o'clock comes and it looks like it's 11 o'clock outside. People are coming to me saying now that they're depressed and they can't get up out of bed, or they can't, eat, or they're not eating enough, or they're eating too much, or they're sleeping too long. And so what I always recommend is light therapy, or to get outside whenever they can, because it's really no medication indicated for seasonal affective disorder, but sometimes it's hard trying to convince people when all they think is, medication is going to fix everything. So sometimes it's hard trying to encourage people to try other things before we turn to medications. But yes, I see more patients now than I've ever seen before. Inpatient, like I keep saying inpatient, in person, I think on a normal day, maybe I have about 16, 20 patients. Now that I'm working from home, the most I've ever seen was 30 in one day, every 15 minutes. New patient appointments are an hour long. So maybe I think in one day I've seen about 5 or 6 new patients in one day, and then follow-ups all the other time afterwards. So I've been more busier now than ever, and we still have new patients coming in. So yeah.
Okay. And speaking of COVID, how do you deal with patients that are kind of in denial that, they're there, but they're not compliant? They don't really think that they have a mental health issue, or it's like, they're there because really families, tell them, refers them. But how do you communicate with patients like that?
So the first thing that I do is I try to bring to their attention what they're doing. So sometimes, like you said, they're in denial and they're just like, I don't need medication, da da da. But I'm just like, okay, but I thought you said that you feel anxious when XYZ. And they're like, yeah. And I'm just like, and I thought you said you had trouble sleeping when this happens. And it's almost like your mind won't shut off, right? And they're just like, yeah. I said, this isn't a normal, like you have to let people know it's not something you have to be on for the rest of your life, but it's something that can help you get through a rough time. Usually, like for SSRIs, like Zoloft, Prozac, we recommend at least a year or 6 months worth of treatment before we stop medications, just because rebound anxiety, rebound depression. But I tell people that, and usually, like if I say, we're not going to start you off 600 milligrams twice a day, we're going to start at like 10, 25 once a day. It's no biggie. If you don't like it, we can try something else. And sometimes that reassurance makes all the difference, because mental health is so delicate. And they're just so afraid that they're going to be put on all this medication, or I'm not going to listen to them, or, whatever the case may be. But after you talk to them, make sure that they know that they're heard, and I'm not trying to over medicate them, and that we're going to start low, go slow, and it's their choice. Then they're willing to try medications. So.
Okay, that's good, at least. Yeah, it's a very delicate field.
Yes. Yeah.
Right. So, one question somebody had was about the DSM-5.
Yeah.
Can you tell us about the DSM-5, or just DSM period?
Yeah, so the DSM-5 is going to be your holy grail. It's going to be your book that have all the diagnostic and statistical criteria for every single disorder you can think of in psychiatry. It is the book that you live and breathe by. Anytime you have a question, you can go to that index or go to that table of contents and look up anything that you need, just to make sure. Because sometimes a lot of diagnoses overlap, and you just want to make sure there's that one subtle difference between like ODD and DMDD or something like that. And you just got to double check that, three times a week or something like that. And you're like, oh, it's this one type of thing. And sometimes you won't always be able to figure out on the first time, like first assessment, what's wrong with someone, but you can get an idea and be able to recommend medications. But sometimes you just won't know. But yeah, that book is there to reference. That's a holy grail. And if you're thinking about going into psychiatry, there's another book called The Prescriber's Guide by Dr. Saul. That's a holy grail. Yeah.
Prescriber's Guide.
Yes, by Dr. Saul. That book, I live and breathe that book, because I knew nothing about it until I started working in psychiatry, and it helps me. It has everything about every single psychiatric medication you can think of, as long as it's not new, like Latuda, or no, Latuda's in there, Vraylar's in there. Yeah, so yeah, it has everything in there, interactions.
Yeah. All right, so somebody want to know what challenges come with being a Psych PA, especially during COVID. I know you touched a little bit on it, but what other challenges or general challenges have you faced as a Psych PA?
You have to make sure you take care of yourself. You have to make sure that you can separate your job from your personal life, because if you take all that stuff home, you won't be any good to anyone. A lot of people try to say, I wouldn't be able to hear about a young girl coming in, talk about sexual assault or rape. That would break my heart. I wouldn't be able to sleep at night if I heard that. But my thing is, I don't think of it that way. I think when they're talking, my job is to listen.
Right.
After I listen, I try to calculate in my brain what medicine will work best to help them, or where can I refer them to get the help that they need. If I get too attached, that taints my judgment as a provider, and I'm not doing the right thing for my patient. So never get too attached. That's kind of like how I live. I detach myself away. When I'm at work, I look at it as, I'm the gatekeeper. I'm here to like help them get the help that they need, or help them get the medication that they need. I don't need to get too involved, but I am very personable because, you're supposed to come off that way, but I don't take it to heart, because if I do, I wouldn't be any good to nobody. So, taking care of yourself, number one, and then also, just making sure, like, if you're going into psychiatry, that it's not just psychiatric disorders. You're going to be treating substance abuse because they overlap and coexist. So just getting yourself prepared for learning like MAT training with Suboxone and different things like that. You need to be prepared. It's not always going to be anxiety and depression. You're going to deal with schizophrenia and, people responding and different things. Like, some of these things you don't want to deal with when you think about it. But, like I said, you got to have a passion for it. So, yeah.
Okay. So I have one more question before we go into the case studies. So you said that you tell patients they don't have to be on a medication, for life. So how do you determine that someone no longer needs to be on a medication or no longer needs your services?
So if they've been stable for a while, now I'm talking about psychotic, non-mood stabilizer, because if they're bipolar or psychotic or schizophrenic, they're going to be on medicine forever. But if it's just like depression or anxiety, and I have an 18-year-old or a 25-year-old, and they're just like, I want to try to see what I'm like without medication, we will wing you off like we were taping you off, see how you do. And if it reoccurs, then we'll restart it. But, it's not a big to do with them. But like I said, if it's mood or something like that, then of course I would say no. I know it would be more risk than it is benefit to trying to see how you do off of it, because they wouldn't do well. But yeah, if they've been stable and in remission for a while, then we can try.
Okay, thank you. Yeah. So now we're going to go into case studies. I just want to let everyone know that's commenting in the chat. If I didn't get to answer any of your questions, I'm going to stay after the session to answer general questions. And if you have more questions for Rashadah that we missed, that we didn't get to touch bases on, then I guess feel free to reach out to her on Insta. Is that?
Yeah.
Okay. And her social, they wanted to know your YouTube. It's Dreams Inspire Life with an S, right? Dreams with an S.
No, it's Reese the Psych PA on YouTube.
Okay.
But it's Dreams Inspire Life on Instagram.
Reese the Psych. Okay.
PA.
Okay. Instagram. Okay, got it. Dreams Inspire Life. Okay, if you guys have more psych questions to ask her that we didn't get a chance to answer, then feel free to follow her and ask her any questions you may have. Thank you so much. All right. So we're going to move on to the case studies. Like I said, I'm going to stay over to answer your questions. You can, if I miss any questions, of course, you guys can always reach out to me also. So anybody want to come on for the case studies? So Rashadah, like I said, the way it's going to work is that someone will come on and you're going to, kind of present them a case study, tell them, the diagnosis and the case, and then just ask them, just questions about like what they would do in the certain case as far as, the communication with the patient or certain things to look out for.
Oh, I'm making a case study.
Yeah. You're going to create.
Lord.
You could be a case you saw today or something off the top of your head.
Okay.
Okay. Does anyone want to come on to go through the case study with Rashadah? If so, just raise your hand.
Hi.
Hi,
Laura.
How are you?
Good. How are you?
Good. This is so exciting. Oh my gosh.
I can't see your video. Maybe I'm just don't. Can everybody see her?
No.
Oh shoot. Let me see. I was like, I literally just saw
It's
it.
right by the mic.
By the mic?
It's this little small. Yeah, it's this little circle. I'm using my phone.
Small circle by the mic.
Oh, here. Oh, that was really close to me.
Hi.
Hi, it's nice to meet you guys.
Hey.
Nice
with
to
you
meet
seeing
you.
this is good.
Thanks for tuning in.
Thank you for having us all. This has been so interesting so far, so I'm really excited for this case study.
Yay! I'm glad you're enjoying it. Okay, hopefully you guys won't beat me up over the head because I thought she was coming up.
Do you want me to come up with one?
So we're gonna play this. No, well,
it's okay, girl. It's okay. Take your time.
Okay, so you have a 25-year-old female presents to your office complaining of decreased need for sleep, complaining of recent substance abuse with marijuana, and complaining of trouble with hyperactivity and issues with irritability. She states that this has been going on for at least 6 months, and she thinks that someone in her family has the same type of issues as her, but she's not really sure because she's adopted. And so she has just been noticing like she's been irritable unrelated to her period or her menstrual cycle, but she also notices at certain times she can battle with depression. And sometimes her depressive episodes get so bad we think about suicide, but we've never had a plan, never had intent. For the most part, when we're going through our depressive episode, though, we have decreased appetite. We have hyper oversleeping. But then when we're in our hyperactivity modes, we have decreased need for sleep. We can spend a lot of money and do a lot of impulsive behaviors. And I think I'll stop there. So you said I give the case study and then I tell them what the diagnosis is?
Yeah, you would tell them what it is, and then you can ask her, what would you want to know about this patient, or what would you ask this patient to help get to that case, to help get to the diagnosis. I'm sorry.
Would I be able to guess? Is this weird? Can I guess?
Sure,
I feel like I know what this is.
Yeah.
Are you talking about bipolar disorder or like a mania?
Yes.
Something made
Yes.
Good job.
Yes.
Good job.
I took abnormal psychology and I was so excited. I was like, wait, this sounds so familiar.
Awesome. Okay. Yes. So, I mean, bipolar disorder, it would be type 1 just because some of her symptoms is more manic-like. So when we say the decreased need for sleep, the impulsiveness, the moments of what we call euphoria, but hyperactivity, another thing or other words you might hear is expansive mood or racing thoughts. It feels like your brain won't shut off. And what's the dead giveaway though with bipolar is their sleep. So whenever somebody comes in and they complain of depression, you always want to make sure that you differentiate depression from bipolar depression, because so many people will be on all these different SSRIs and SNRI, all these different medications. And the dead giveaway is, oh, I've tried this medicine and it worked in the beginning. And then it seems like it stops working. They're probably bipolar. But those are just some things to keep in mind. So some things that I said that were kind of clues to like bipolar disorder. Number one, family history. They have to have a family history. It's hereditary. You can't go outside and catch bipolar. They have to have a family history of it. And it has to be a first-line relative. Whenever you hear that, never be afraid to tell someone that's what you're thinking. Usually, sometimes I've seen psychiatrists and stuff in my area not want to actually give a kid that label of bipolar disorder, but it is what it is. Sometimes people wait until they become teenagers and stuff like that to give them an actual diagnosis, because in puberty and things like that, when the hormones are going, sometimes usually that's when we first see a manic episode or a hypomanic or anything like that indicating bipolar disorder. But just having that information of a family history kind of gives you an idea of what we're probably dealing with. So do we ask you want me to ask her what we treat it with, or you want me to tell it? I'm sorry. You probably told me this 500 times.
Yeah, you can say what you treat it with.
Okay, so being that she's like in her 20s and she's a female childbearing age, my first line is Latuda. Latuda is FDA approved for ages 10 and up. I like Latuda because it's safe in pregnancy. It is the only mood stabilizer that's safe in pregnancy. Now, every now and then you might see Lamictal used in pregnancy, and that's kind of give or take, but Latuda is. So you can give Latuda, and it starts out at 20 milligrams one time before bed, but you want to make sure they eat food. So a way I remember it is Latuda with Fuda. You always want to give Latuda with Fuda, because if you don't eat, then you only get half of the medicine. So if the lowest dose is 20 and she takes it on an empty stomach, she only gets 10. So Latuda is actually metabolized in your gut versus, your liver, so to speak. And so it works better with food. And yeah, that's how I would treat it once a day, one pill once a day with food. At nighttime, though, that any antipsychotic is not a morning med. They'll be asleep all day. Okay.
So Laura, I have a question for you.
Go for it.
So you already, one important question that she said, or she answered, was that she's a woman, childbearing age.
Right.
So you want to, of course, make sure that, she's not pregnant. But you said it would be safe in pregnancy, but always, do a pregnancy test or ask them about last menstrual period. So what else would you want to know specifically with psych medications? What's an important question you would want to ask the patient when starting with any medications? But
have you tried anything before, maybe?
Yeah.
Or do you have allergies, or I don't know, any what's the word I'm looking for? Any bad reactions to previous mood stabilizers?
Okay, yeah. So, with psych medications especially, there's a lot of side effects and a lot of interactions with other medications. Yeah. So you want to ask them if they're on any other medications, or if they're on, or specific medications around, or other medical problems that can impact them.
Makes sense.
Yes.
Very important, for sure.
Yes. Okay, great. Good job, Laura. Good job getting the diagnosis. I try not to ask you guys the diagnosis because I don't know where you are, what stage you are.
I'm so weak.
But you did great.
Thank you. Yes, you did awesome.
You guys are so great. Thank you for having me with my wonderful screen being observed right now on the frizzy hair. It's so good.
It's all right, girl.
All right, we're going to do another case. All right, she did great. Thank you so much.
You did.
Okay, another case. Let's see if there's any questions that we can touch on. It says, is it unusual for adult patients over the age of 18 to develop ADHD?
No, ma'am. So I'm one of them. I don't have ADHD, it's ADD. ADD is what is mostly overlooked. And ADD, undiagnosed, cause a lot of problems with anxiety and depression. So usually those are that usually have things and nothing really tends to work. But you start asking questions like, how is your concentration? Are you easily forgetful? Or can you read stuff and then 2 seconds later forget what you read on the paper? Or does it take real effort for you to be able to get or grasp something? And usually when I start asking questions like that, and they say yes, I start them on Strattera. Usually over the age of 18, insurance companies do not like to cover stimulants. So I usually start my adults on Strattera 25, 1 capsule in the morning. And when they come back and they say, oh, I've seen a decrease, or I can concentrate so much better, their anxiety goes down and we're able to take away the other medications and usually go forth. But normally college students, like I said, I was in PA school or after PA school when I was finally diagnosed with ADD, and I diagnosed myself. And which was terrible because I was talking to one of my patients and asking questions and I was like, God, that sounded a lot like me. And lo and behold, yeah. But no, it's not uncommon.
All right, thank you for that. So we have Ikra. Ikra, can you turn your camera on, please?
Yeah, hold on 1 second. I'm sorry.
Oh, no problem. Hi. Thank you for coming on.
Thank you for having me. It's my first session. I just found out about this program 2 days ago, so I'm very excited.
Awesome. I hope you come to more.
I will be. This is amazing. This is awesome. I just was not ready to be live, so.
No, it's really laid back.
You're fine.
Yeah, as you all can see, I'm really laid back and chill. So I make it fun for you. I try to make it a relaxed environment. PA school's gonna be stressful, So.
Oh Lord, yes.
All right, Rashadah, let's go on with the second case study.
All right, so you have a kid that presents to your office and they're just very, very irritable. They're around 8 years old, a male. Usually the mom says that they're having outbursts, like 3 outbursts, usually really, really bad a week. They become physically aggressive, or they do property destruction when they can't have their way. They don't listen or follow directions. They purposely do things that's going to get them in trouble. And they have just a hard time trying to get them to behave in school and at home. Yeah, and they're very, very irritable. So I think, again, do I tell them the diagnosis or do I have her guess? Do you want to guess?
Do you want to guess what it could be?
Uh-oh, she went away.
Wait, can you hear me?
I hear you, but we can't see you.
I'm having connection issues. It's telling me my connection is low. Sorry.
It's okay. It's okay.
We can see you guys either, so I don't know what's going on.
It's okay. Do you want to still stay on?
Yeah, I mean, if that's okay with you.
Yeah, of course. So, what do you think the diagnosis is? If you don't know, then it's fine.
I'm actually not sure. How old is the child?
The child is around 8. I forgot to mention that this has been going on for 6 months, and it's in home and at school. Just irritability.
Could it be autism or ADHD?
No.
Then I'm not sure.
You're not sure?
We don't expect you to know.
No, we don't. We don't. It's fine. So it's actually disruptive mood disorder, disruptive mood dysregulation disorder. I see this every day, almost every day in kiddos, and it's mostly boys. I don't really see a lot of girls with this. The giveaway was 6 months. It has to occur at home and at school. They have to have at least 3 or more outbursts per week, and they have to be irritable outbursts for most of the time being. And so disruptive mood is kind of one of the weird ones because everybody want to go straight to mood stabilizers and antipsychotics when they hear this. But actually, there's no FDA approved medication for DMDD disorder. So usually we treat them with whatever works. Usually in kids, if I can get them stable on an SSRI like Prozac, Zoloft, I'm fine. But if we need a little bit more, then I go straight to Abilify. I don't really like risperidone. Risperidone you can do, but I don't like the man boobies, the prolactin and things. So I don't like that. But you can use that.
Okay. All right. So let's see. As far as being that this is a child, what would you ask, mom, since you're, you have your patient is 8 years old, what are important things that you'd want to know about the child?
Maybe their daily activities. Oh, am I back? Okay.
Yeah.
Daily activities, or if they're taking anything if she's treating them for anything else, like any medications that they're on, not necessarily for a chronic disorder, but anything, even as simple as Tylenol. If she's giving that.
So what? I guess I'll let you answer that, Rashadah. What exact other things that you want to know about the kid to help you get to that diagnosis?
You always want to rule out lead toxicity. Like if they live in an old house that have lead can cause irritability and strange behaviors, like very violent type of behaviors in kids. You want to make sure they're up to date with their shots because you do have some parents out there that don't vaccinate their children. And I know some, not a whole lot. And I can't really say them off the top of my head because I don't want to say the wrong thing. But I know sometimes if they get a disease, it can come across with psychiatric symptoms. But of course, you want to make sure there's not environmental things going on, like the mom and dad are getting a divorce, or, they feel like they're not getting enough attention, or like some type of outcry. Like you want to make sure it's nothing like that. You want to rule out all the other contributing factors And then when we get down to it, you know, family history, make sure they're not a budding bipolar or anything like that. But after you rule all of that out and get you some labs, if nothing else is coming about, you can pretty much say, you know, it's DMDD.
Okay. So what would be in the differential? What other diagnosis would you think of? Would like ODD be one, oppositional defiant disorder? Because I was also thinking about antisocial personality disorder.
Oh, no. No. Antisocial. So the difference with them, I'm glad you asked that question. So if you have ODD or DMDD, both of them cannot coexist. So you have to have one or the other. ODD, we mostly see with ADHD kids, not necessarily, but most of the time you do. And then as far as antisocial, you got to be 18 for that one. Conduct disorder, now, yeah, conduct disorder is different. So like it goes ODD and then conduct disorder, then antisocial personality. So
okay.
Yes, it progresses as they get older.
Gotcha. You see, I didn't even know that. Okay.
Gotcha. Fine.
Yeah. A question? Yeah.
So the disruptive mood disorder, how does that progress? Like, is there like an age for that diagnosis, or can like older people get that, or like how does that progress throughout a lifetime?
Disruptive mood disorder.
Yeah. So, I mean, usually it's before the age of 12. Sometimes some people are not forthcoming with their mental health or wanting to get help. But usually up until the age of 18, you're kind of cutting it. Usually it's before the age of 12 that we diagnose with DMDD.
Okay.
Yeah.
Okay. And thank you, Ikra. I actually have a question before we end this case study, because somebody asked about the home environment, and that brought me to think about, you know, a lot of the time social issues lead to psychiatric disorders. So do you ever interview children alone, or do you end up like, you know, have the parents leave the room, bring in a social worker or something? Like, how do you handle that when you think that it's something underlying at home causing it and you don't want the parents in the room?
Yeah, so I mean, if I feel like that's the case, I will ask either the child to come with me. Like we have this little room at my office, and I'll say, yeah, we're just gonna walk out here. You want to come with me, and leave the parent in the room, or either I ask the parent to step out for a little minute, or I'll call the child back first and ask the parent to stay in the waiting room. Usually if I'm suspicious of like abuse or anything like that, that's a direct call to CPS, just to let them open an investigation and investigate what could be going on. I can even call my supervising physician if we have to put somebody inpatient for whatever reason I kind of make up just to protect the child, we will. Sometimes I've seen trauma, sexual abuse, you know, some foster parents come across saying they're seeing things or they're seeing people and stuff, and it's not real hallucinations. It's the chemical imbalance in the mind after the trauma that's causing what we call hypervigilance. We don't call it hallucinations. Schizophrenia don't present to your early 20s, so we don't have to worry about that in children. So it's trauma related. Yes. And so usually I see that, or when they play with their feces or urinate in the bed and things like that, that is trauma related. So we treat that with SSRIs, all of it.
Okay. But, wow. I'm learning so much. This is so interesting for me as well. Thank you. All right, Ikra, do you have any more questions?
No, I think that's it. Thank you so much. This was so great.
Awesome.
Yeah, no problem. Thank you.
Thank you. All right. Goodbye, Ikra.
Bye.
All right. Oh my gosh, that was awesome, Rashadah. Thank you.
Yeah, no problem. Like I said, thank you for having me. This is actually fun. It wasn't as intimidating as what I thought, because I was like, oh, Lord.
No problem. No problem. I love the cases you presented. Let me just see if there's any other questions that maybe we can quickly answer. We have about 10 minutes left.
Cool. Okay.
Let's see. What do you do when the family has never gotten mental health treatment or diagnosis? I guess it sounds like as far as like counseling the family, whether it be their children, wife, husband, or whatnot.
It depends. Like overall, I give that spiel about how mental health is important, just as important as any other health or a specialty. And I try and let them know, like, okay, like for instance, I had a mom that didn't want to treat her child for ADHD. And I said, okay, well, if you don't treat them for ADHD, or she wanted to try fish oil or something, some mega root, something from over the counter. And I had to explain to her that ADHD is a chemical imbalance of norepinephrine and a little bit of serotonin and different things. So kind of like what I talked about with the adults having ADD undiagnosed, ADHD is worse. So like you can actually have trouble holding a job, holding relationships, advancing in your educational career and things like that later on down the line. And then it ends up in substance abuse, with you abusing meth and different things because you can't get what you need or you don't know what you need. So yeah, I would definitely say I counsel them on what the consequences could be if you don't treat your child, and would you want that for your child? And then they understand, and then they're like, okay. Right. So ADHD is something they're going to have to be treated for the rest of their lives, unless they decide not to be on it. But you know.
Okay, thank you. And they asked, can you talk a little bit about your coaching program?
Oh, yes. Thanks for reminding me. So the coaching program, it is launching next week, and I'm so excited. So what you need to do is fill out an application. Applications are now open. The link is in my bio. After I read your applications, me and my other two my co-founder and my other mentor review your applications. We pick at least 13. That's our lucky number this year. And we will send you emails, and then you'll be able to enroll. So depending on where you are at, we have 3 different packages that we're offering. The first package is called the Pre-Cohort, and that lasts from January to June. It's 6 months. And during those 6 months, we go through your personal statement. We pick your top 5 schools. We make sure your prerequisites line up. We talk about mind training, so knowing why you're going into PA school and getting your mind right, because once you get into PA school, it's just like what to expect. Each month, we will have a certified PA come in and talk to you about their specialty, or either we'll have a PA student come in and talk to you guys about what they thought PA school was like, and then what PA school is like for them. So to give you guys an idea of what you're going to get into, not saying it's a bad thing, but you got to be prepared, because it's like drinking water out of a fire hose. When you get into PA school, you got to be ready. So we work on that. And then, and we also do mock interviews in case you get accepted or get offered an interview. And we also help you, of course, apply through CASPA, make sure you're saving your fees for your CASPA, applying for schools, all that stuff. And then June through December is our post cohort. So those are for current PA students that maybe they're a part of an inaugural class that don't have mentors yet, like I was. And maybe you want somebody to talk to. Maybe you're the only person that's going to medical school out your family, and you're in school, or you're having trouble with studying and things like that. So we create this resource list for you, and we're just there for support. It's not exactly a curriculum like with the first cohort. It's more like as needed basis. We get you prepared for clinicals in a sense. We look over your CV at the end of clinicals. We try to give you some tips for studying for the boards, that type of thing. And then we have,
No, I said that's amazing.
Thank you. And then we have the DIY package, which is do it yourself. We're basically taking all the homework assignments from the first one and all the resource lists from the second one and putting it in a nice little package, giving you a link, and you can go through it at your own pace. So those are our 3 packages we're offering.
I wish I had that when I was applying to PA school.
I wish I had that too. I had YouTube and Google. That's all I had.
That's all I had too. That's all I had too. At least we made it, but I know it's gotten a lot harder. I know it's gotten a lot harder. Like some of the people that I've been mentoring, like they said a lot of the school requirements have even changed. They require a lot more science classes and definitely modeling more like of the medical school. So the biochemistry, the genetics, Gorga 1, 2, all that. So
yes.
Okay, we have one more question. And I really wanted you to answer this, being that it's involved with COVID and telehealth. It says, Ashta wanted to know, how are you able to determine if there is abuse involved via telehealth?
You mean physical abuse?
Yeah, it sounds like physical abuse. If a child or somebody's being abused, like just kind of seeing them on the computer, being that you can't really do a full assessment or see them in person.
Usually I get a feel from it. Like if the child, first of all, if the parent's doing all the talking, I'm suspicious of it. And I always keep my eye out for factitious disorder. That's in every single specialty. You got to keep your eye out for factitious disorder when the parent come in trying to speak for the patient all the time. That's why I usually talk to the parent for a little bit and I'm like, okay, so how are you doing today? You know, I direct my attention to the patient and have them talk to me. If it seems like they're scared to talk to me, like it's more than just anxiety or something like that, my antenna goes up. And usually I get my admin involved. And I also get my director involved and I let her know some of my concerns. Now, if it does come back, I'm suspicious in any way, I'm calling CPS. That's usually my protocol because it's better to call CPS and they do an investigation for nothing than to not call them and something is going on type of thing.
Right.
Yeah.
Okay, I'm sorry. I have one more question. I lied.
Yeah, I'm here for it.
Can you tell us, because I had a patient, I think, who was diagnosed with it. Well, it was a patient that came in with her daughter. Her daughter was the patient. But they said the mom had a Munchausen syndrome.
Yes, Munchausen by proxy. Yes. Yes, so.
Tell me about that, because I'm still like, what the heck?
So Munchausen by proxy is now called factitious disorder. These are people.
Okay, it's called factitious disorder. Okay.
Yes, these are people who love to play the victim, and usually, if it's not on themselves and it's on their daughter or whatever, it's by proxy. So usually they come in and they're like, "Oh, they're so sick. Oh, they need a GI tube. They need this. And they put their child through all these procedures and make them look so sick. Like, have you seen The Act or heard of The Act off Hulu? If you haven't seen it, I don't know if it's up there anymore, but The Act, it was this girl. It's a true story. Like, her mother made it look like she had cancer. She couldn't have sugar. Her hair fell out, all this stuff. She would give her seizure medication.
ACT, The Act, ACT.
Yeah, The Act. And she was on Dr. Phil and everything. And her mother for years made her look like she was sick and wasn't nothing wrong with her. She'd been taking seizure medicines and all this stuff and putting nair on her head to shave her head bald. She was in a wheelchair and she could walk. Like, her mother did all this stuff for sympathy. And she got money and collected money. But it wasn't the money. It was the sympathy that made her psychologically happy. So they want to be cared for. They want you to feel sorry for them. That's what drives that. And usually it's people in the medical field that sadly, it's people in the medical field that ends up with factitious disorder because they know all the ins and outs of all the symptoms to look for.
That's true. They know what to make the patient sick. They know the diagnosis. They know. Wow.
Yes.
Wow. Wow. That's. Also, she ended up killing her mom.
Yes, she did. Once she found out the truth, I mean, she could walk and everything, and she actually got up one day and drank soda and all this other stuff and saw she could drink sugar. Like, she took her whole childhood away from her. I mean, I'm not saying it's right, but she killed her mother.
Oh my gosh! Wow. So how do you even like end up getting a patient like that? Because I feel like it's going to take years for people to realize that it's the mom or that has the issue, and it's usually women, right? That's diagnosed with this, not men.
Yeah, so I don't really see a lot of men. It's usually women. So what I would say is make sure when you're getting the history, if they're bringing in all these records and stuff, you know how sometimes we call the other specialists or older providers. I would call and ask them, did she also bring in this big stack of medical records to you too, saying that she's been diagnosed with this and you just ran with it? Like, did anybody actually diagnose this child with that? Because that's how the mother got away with it. They said they was involved in Hurricane Katrina and she lost all her medical records and this was all she had left. And they were medical records that she forged. And then she collected over time when she went to all these new providers to make it look real, like the child was sick and she wasn't. She wasn't sick.
Watch this. Oh my gosh.
So you got to pay attention to like the interaction between the child and the mother. And like I said, do not let the parent do all the talking. Like, you have to talk to the child, because that's what the providers would do. They would listen to the mother and not listen to the child. And then she got whatever she wanted done to her, like GI tubes, all of it.
That is
terrible.
Horrible. That is, oh my goodness, that's horrible. Wow, because then the child ends up having a mental health disorder too. Like it just becomes a cycle. Wow, thank
Terrible.
you. I've always been interested with that. Like emotional. Wow. Okay. So it's 8:00. I won't keep you too long, but this session has been so interesting because I love psych. I actually really love psych. If I could do another specialty, it would probably be psych because I actually did some psych when I was an LPN before I went to PA school. So I know some. Yeah, I have a little psych background. Of course, it's not as good as yours. I forgot some of it too. It's been years, but I love psych. So
thank you. Come on over. We'll be happy to have you. We need more providers. We really do. We're about to get real busy after COVID. So please, we need some help, please.
Thank you so much, Rashadah. Guys, once again, Rashadah was great, of course. You guys can follow her on her social media at Dreams Inspire Live. Her YouTube is Is the PA. The Psych PA. If you have any questions, if you're interested in coaching, mentorship, she's great. She's here. She knows a lot, very knowledgeable about the psych field and helping you get into PA school.
Yes, thank you for having me. I appreciate you so much, and every last person who attended this session. Thank you for taking your time out and listening to us in this interview. And I appreciate you. Anytime you have any questions, even if it's non-psych related, you can always hit me up. I'm willing to help you any way I can. So
thank you so much. Thank you. So guys, I'm going to stay tuned because I saw you guys had some general PA questions. I'll stay tuned for about 5 to 10 minutes to answer some questions. But Rashadah, thank you again.
Yes, thank you.
We'll be in touch.
Of course. And you guys have a good night. Thank you for having me.
Good night.
Bye.
Bye.